I want to end, I think we've got 20 minutes left to talk, the end of life, the end of the presentation, to talk a little bit about end-of-life care. Because this is, you are all going to deal with this, and you're going to deal with it a lot. I'm going to present a case. This is a very recent case, and I learned something from this case too, and I want to share what I learned. And this was a 102-year-old gentleman who I knew in the community, who was admitted in January to this facility with vascular dementia. His MMSE was 12. He had lacunar infarcts. He was agitated and paranoid, wouldn't let people come in and help him. It took a lot to, finally get home care in with him. He was a gentleman. He was a lovely man. It was a complete change in personality with this fellow, and once the dementia started, and he had end-stage OA of his hip, so this is the way he walked, around the retirement home that he was in, and he had a lot of pain. And we used to give him injections into his hip once every 3 months. He went for fluoro injections in his hip, and I controlled the pain because he wasn't a surgical candidate, so he got Depomedrol into his hip. He had severe problems with constipation, and basically it was community burnout that brought this guy into, we barely got him into the facility because he was so resistant to coming in. And his meds on admission were Enteric-Coatis ASA 81 milligrams for stroke prevention. He was on donepezil for his dementia and risperidol because it was the only thing that can control his agitation and let caregivers come in and help him for the 18 months leading up while he was on an emergent wait list. And venlafaxine for his mood, and he was taking Tramoset 1 TID for hip pain. And his pain was really well controlled. With the Tramoset, he didn't need any further injections in his knee. And once he was in the facility, I tapered him off the donepezil after he'd been in for about a month, and he wasn't worse off of it. We tapered him off the risperidol. Again, I wait till people settle before I take them off the drugs after the move. And we left him on the venlafaxine Tramoset. And I got a call. He was getting he was just blowing up like a balloon with fluid. He was getting progressive CHF over 2 weeks, felt weak, no chest pain. When you asked him, no shortness of breath, but he wasn't really getting out of bed at all. And his memory was so short, you couldn't say, what about when they took you and put you in your chair and things like that. He was okay in bed. He denied any pain. He had generalized edema. He was leaking he had leakage from his arms and his legs from the edema. His JVP was up. It was 3 centimeters. His blood pressure was low, 90/48. He was breathing. He was tachypnic. His O2 sat was good. On room air, 96%. He had crackles in both lungs. He wasn't really leaving his bed. They were getting him up into a chair and taking him in for meals. When this guy came in, he was still walking, into the facility. And he was sleeping most of the time, which was unusual for him. He was a pretty active guy, but he would certainly stay awake during a conversation. And he had a little low-grade delirium. He's kind of restless in bed. He was perplexed and frustrated because he had trouble concentrating on conversations, and he was a little distractible. And he was thankful for the visit. Thanks for coming, Doc. What do you think? What's happened to this gentleman? Right, he was walking and talking and interacting in the facility, and he'd been there for 2 months, and suddenly, boom, there was a massive decline in his function. Yeah, right. I thought this guy clearly had congestive heart failure, which was new. He's never had it before, and severe congestive heart failure. And he probably had an MI that caused it, that it would go so suddenly. He would suddenly develop this, right? Any other thoughts about him?
He's on his way out.
He's on his way out. There's a good chance this guy there's something bad has happened to him. He's got bad heart failure, and he's on his way. He could be dying, right? This is the challenge. So we come back to the goals of care again with this gentleman, and talking. I knew this fellow fairly well, and speaking to his daughter. So for him, his biggest concern was the weakness. Oh, I have no energy. That was number one. Hip pain was pretty well controlled with the Tramoset. The restlessness and delirium he was restless. And I said, yeah, I can't follow what's going on. And for the staff, it was a bit of an issue, because he would sundown in the evening. Paranoia and agitation were well controlled. He had really minimal pain. And he had very minimal breathlessness at rest, and he wasn't moving very much, but he only had breathlessness when they moved him into his chair and took him if he had to do something. It's morning care. In terms, his goal also was he wanted to improve his function. He said, I want to get back into, the activities they were doing. I don't want to be in bed all the time. And in terms of healthcare, absolutely no transfer to hospital for this fellow. He's 102 years old, and he was happy, finally settled in the facility he was in. And there was no way he was going to emerge. According to the daughter, and I certainly supported that. So we thought, okay, let's treat his heart failure and see what happens. Right? Is that not unreasonable? Because again, it's not really short of breath, no pain, no angina. So we put him on a low-dose Lasix, stepped it up to 40 milligrams because the edema was a huge issue. His skin he was spraying lakes left and right. And we added in spironolactone and put him on a very tiny dose of ramipril. You remember, his blood pressure was 90 systolic at start, right? So we're dealing with something you have to be very careful with the meds. And a very tiny dose of bisoprolol. So we maxed out his CHF treatment to say we did our due diligence monitoring for side effects. And his BNP came back at 10,000, his TNT was up, his GFR was low, right? The guy's sodium was low, it was 130, his albumin was low, okay? And at the end of this attempt to treat the heart failure, and I'd say 50% of the time people do get better, especially if they're shorter breath. Again, if you want to treat someone who's short breath of pulmonary edema, get rid of the pulmonary edema, right? Just like someone's got rheumatoid arthritis, don't give them morphine. Treat them with prednisone. Sorry, Amanda, go ahead.
I was just wondering, in this situation of someone who's really frail, starting off with a low blood pressure, and a lot of medications were added, and still his pressure is low, is there any room for digoxin in this case to kind of improve the pump function?
It's a good thought, Amanda. What do people think?
It's in renal failure. I think there's a French word for using digoxin in this situation, something about disaster.
Yeah, digoxin is you have to be very, very careful with older people. I use it as a third-line, fourth-line drug when people are in the community, and it does improve cardiac function when people have rapid heart rate, but again, it's the therapeutic threshold is so, there's a guy who's borderline delirium now. I would be very careful. I wouldn't, we didn't use it. Would anybody not treat him? You can see I gave him sort of full medical treatment for congestive heart failure, right? And ischemic event. How many people think we shouldn't have, we overloaded him with meds?
There's really no downside to it. I think you've got to treat.
And some
He was
people,
going down, and so I don't see any downside.
and he told us, or some people tell me, Dr. Rosenberg, I don't want anything that's going to prolong my life. And those kind of people, I may not treat. Or I'll say, like, if they're breathless, let's try this first. But yes, right, he wanted to get better. And his wife and his daughter was shocked at the deterioration in his function. What happened. Okay. But in this kind of situation, what happened? There was very little improvement in his symptoms. I would say, nil. There was no improvement in his function. His edema got a little bit better. He wasn't springing a lake, but it was still had a lot of edema. This guy knocked out his heart. And even his blood pressure went down to 80/40. Okay? So, and he was sleeping most of the day. They still got him up for meals because that's what they do in facilities, right? He got to eat and get up, and he was like exhausted, the process of getting into his chair. And I asked him, he said he had no shortness of breath, he had no pain, and he said, I'm fine, I'm just tired. He was in his bed, and I'm tired of people also I get too tired sitting in the chair. They sit me and they park me in the hallway, right? What's this man's palliative performance scale? How many people have used the PPS? How many people have not used it? Good. So what's his PPS? 30? Okay. Okay. I would give him 42. Yeah. So most of my patients, I start at 50. I don't even look at the 60, 70, 80, 90s, right? That stuff. I start at, if they're in bed all the time, if they're in bed most of the time, they're at a 40. If they're sitting up most of the time, they're a 50. In that range. And then you can work your way down. I sort of work across. So if they're in bed, if they're partly in bed, they're a 40. If they're totally bedbound, which this guy should have been, he pretty well was, that brings them right down to a 30, right? I mean, they put him in a chair, but technically he couldn't bear being in the chair. And then once people's level of consciousness and their intake gets reduced, you get into the 20s and the 10s, when they get into a coma and they're not eating and drinking. Is that, Christine, you might want to make a comment about that? So there's a couple of real quick shortcuts. It's like doing APGAR scores that you can do with PPS, and it's good to track people, right, in their progress. So we've got this guy with 30 to 40 PPS. What are we going to do with him, and what are we going to say to the family? How would you handle the situation? Should we keep him on the drugs, the bisoprolol, the spironolactone, the furosemide, the ramipril? Should we keep him on those drugs?
He said he's feeling fine.
Well, there's been a benefit.
Okay. So he was feeling fine at the beginning. He was just perplexed. He was weak, he was fatigued, and he was exhausted. Remember? And that's why I say it's really good to go back and do that good history at the beginning. He had no shortness of breath at the beginning, which we looked at this guy just swollen up like a balloon. Why is he so edematous with no shortness of breath? And you examine me, he had crackles and his JVP was up. So there was never shortness of breath. There was never chest pain with this fellow. Okay, except I never saw when they moved him, but I'm sure he was a little short of breath transiently. His fatigue was his symptom, right? So are these drugs making him less fatigued? That was his symptom. Are they making him less fatigued? No, it's getting worse. His other goal was to be able to walk, move again and go and participate. Are they helping him function?
No.
No. Would we keep him on these drugs?
No.
No, and his blood pressure went down to 80, and he slept more. So I took him off. Withdrawing, we tried him, and this is the important thing in geriatrics, in frailty, in palliative care, is do something and reassess, and reassess, and reassess. And and it's a lot of it is this iterative process. And if he was better, I would have left him on it. So in this case, I thought the only thing that was possibly of value were the diuretics with him, because there was a little less edema. Okay? What else could we do with this gentleman?
Introduce a small dose of morphine.
Okay. What would you treat? What is morphine used for?
Well, it improves cardiac function.
Okay.
But and any shortness of breath that he might have will improve that.
Okay. Does he have shortness of breath?
Only with movement.
Yeah, but he's in bed all the time now.
When he's getting up for meals.
They were getting him up until I talked to them.
Okay.
Okay, so what do other people think? There's no right answers here. We're having a discussion. But does anyone else, how many people would put him on morphine? Okay, how many people think morphine may not be a good idea? What would the downside of morphine be?
He's fatigued now.
It's fatigue.
He's complaining about fatigue.
Yes,
So,
and he could still hold a conversation, talk to his daughter, talk to his family when he was. What's the other downside of morphine?
Renal failure.
His renal failure
And constipation.
and his constipation. And this guy's a little bit confused, right? And you can make him. There's a chance he's got sort of just on the edge of delirium to push him into a full-blown delirium. And we know this guy was paranoid and agitated. Before he was on risperidol, we had him off the risperidol. What would you talk to his family about? What, any other drugs you would put him on? Anyone have any ideas?
He's not breathless.
No. If he was, I wouldn't hesitate to put him on what Chris said, to put him on morphine Dilaudid. I wouldn't hesitate.
How about a stimulant?
Stimulant? Okay, so maybe because fatigue is his big issue, so you could think about something like methylphenidate or modafinil, something along those lines, right? And I do use that for people, who are very, very, where they want to be more awake.
possible,
Would there be some concern with his heart function?
It's generally pretty safe. Yeah, I use 2.5 milligrams, but what's happening to this guy?
He's dying.
Right? So what would you tell his daughter is saying, what's happening to my dad? I know he's 102, but he was he's limping into the dining room until 3 weeks ago.
So,
Good?
big change. The best you can say is he's very likely had a significant heart attack.
Exactly.
And that's
So we can say that's exactly. We got that his troponin was up.
Yeah.
He had massive elevation of his BNP. We didn't send him off for any X-rays.
Mhm.
I don't always do that degree of blood testing, but this was a big change, and then I could communicate. He's had a massive MI, and he's dying. Okay. So end of life orders. Sorry, Christine.
In talking to the family, there's often so much emotion. And whether you do it over the telephone or in person, with those conversations that can be so distressing is to really ask them what they have seen. And because they will often say, they might come in asking you what's going on. But if you say, I wonder what you think is cool, what you've seen in your dad, and they'll often say, I think he's dying. And so then that piece becomes so much easier. What would you say to the family? I would actually think about what would you ask the family.
Yes, exactly. What do you think is
And
going
what
on?
they're
And
hopeful
and
for
that's
their
often-
loved ones.
I lead often home is, what have you seen with your dad?
Yeah.
And what do you think is going on? So I left it just to be able to finish this, to bring it to a closure, because he's going to break my legs if I'm late. Me is I left backup end of life orders, and I do this when I see someone who I think is dying. You don't want them on the weekend in pain and breathless, and the nurse is scrambling to get some medications, right? And trying to find a doctor and the staff has changed, and so we said, this guy's, when he has trouble swallowing, we kept him on the, Lasix and the spironolactone, stop his oral medications. Are people familiar with this standard end of life? A lot of the facilities now have a protocol that you can check everything off.
Everything that's listed there is on the clinical order side, all those medications for those indications.
Okay. So these are the typical drugs used: a narcotic for breathlessness or pain. A lot of people, when they're immobile, they're uncomfortable. When they're immobile, they're completely bedbound. Lorazepam is good sublingual or subcutaneously, and the sublingual works beautifully. You just draw it. I take a pill, crush, in water, and draw it up and squirt it under their tongue. Let's say you can't put the pill under their tongue. Haloperidol if there's nausea, if there's delirium, atropine, and sometimes we use Nozinan, especially if people are really agitated, or if they're Parkinson's. If you want to use something with a little less EPS. And then atropine, and I always put an atropine when someone is not conscious and for end-of-life secretions, because I've seen nurses give atropine to people who are alert, and then they're confused, and they're delirious, and they've got a dry mouth, and they're blurred vision. So atropine I save for when they're unconscious, and they have that end-of-life secretions. And the other thing I want to mention about end-of-life orders is that when I actually start these drugs, like Christine, I put people on a regular dose in a facility, because too often you put PRN. This guy didn't need anything started yet, but these were backup orders. But when I'm starting someone, I put them on a regular dose, because all too often I've come back and, when was the last dose? Oh, it's just PRN. It was given 12 hours ago. And the person is in pain and they're breathless. So I often will do it, I'll put them on a regular dose initially, and when it's clear that they're at the end of life. So 10 days later, and again, I left the facility, and this guy was fine, and I just said, you don't have to take him to get him up in his chair anymore, and here's some backup orders if you need them, and everything was cool, and we stopped a bunch of drugs, and call me if he's worse, right? And 10 days later, I got a fax back, and nothing had been started, saying he died peacefully, thanks for your care. So I called his daughter. I always phone my patients' families after someone dies. And her question to me was, Dr. Rosenberg, were you on holidays? I said, He said, why did they drug him with morphine? There was a Dilaudid order. And she had all these questions. Why wouldn't they give him water or an IV? He was congested. Did he have pneumonia? Did you not treat his pneumonia? Did that kill him? And then we had a long discussion, right? and she was understood and relieved. And the point I learned from this is that I got caught with my pants down, because normally once I start someone on sub-Q treatment, I go in every day to see someone. That becomes, palliative care, and that's like hospital care, right? You need to follow up on these people, and you may think they're in good hands in a facility. The nurses are changing, unless there's someone with continuity overlooking, and the nurses often need a little guidance. They need the confidence to push up the dose. They're grimacing. We're using our Abbey pains. They may not have the Abbey pain scale. I know, that it's okay or to give the dose regularly, or, to fine-tune the end-of-life care. And it's important families have questions, even at this stage, and their observation, they need support. And I was MIA, because when I left him, he was fine, and he wasn't on any drugs at all. And I didn't get back. I was planning to go the following week to see him. And it got pushed, to some other time. And I felt I was negligent in this case. And what I do now, and the lesson I learned, is that I put on the orders, if end-of-life orders commenced, fax me right away. And I called the director of care and said to them that I need to know when you're starting someone on a parenteral drug, or your stopped oral medications or the other things, because we are their doctors. And people do have questions. And this was a half hour, this was a 40-minute conversation, and an important conversation. Now, a practical point for you, I didn't know this until about 3 months ago, is that if someone is palliative, and this person was end of life, but if they're palliative, there's a billing thing that you can only bill every 2 weeks. If someone is designated palliative, you can bill every single day for 6 months. So you'll get paid for the good care you're doing, and you get paid $40 a visit, because there's recognition that palliative care takes more time than regular care. So use this billing code, and you don't have to wait till the end of life, the last week of life, where it's clear people they're dying. If you have people that something bad has happened, they've had a stroke, they've had an MI, we're moving away from active medical care into supportive care, put on your billing code palliative care. Put that, and that lets you do the kind of follow-up you need to do and get paid for the work you're doing. So, in conclusion, for end-of-life care is recognize when people are close to the end of their life, and sometimes it's not always obvious, that they're in the final week of life, especially that very end. But most of the time, we've talked about tips coming back to our very first torch session on, on severe Alzheimer's disease and dementia. When people have trouble swallowing and they're aspirating and getting recurrent infections, these are people who are moving into a palliative mode, right? So there are things that we can use to guide us. When people are failing on medical treatment, they've had a massive event, they're moving to end of life. And communicate that, and as soon as you recognize that, communicate that with families and communicate that with people. So I had a lady who burst an aortic aneurysm on Wednesday, and I told her, I said, Geraldine, this is what's happened, and you're dying. And she knew, and she said, I thought so, and I don't want to. And it was important for me to communicate to her, because there may be stuff she wanted to communicate to her family, and to think about that. She died about 20 hours later after the ruptured aneurysm. So, the communication is paramount. Communicate with the patients when you're able to. Communicate with families. Listen to their questions, as Christine keeps teaching us. Listen. What are their questions? Because what we may seem obvious to us is not obvious to them. And some of the questions, I'm always surprised. I never fail to be surprised. And they're important questions and perceptions. And it's good to establish the goals of care ahead of time. But remember, goals of care is a moving target. And reevaluate those goals of care when you do them. When you have people at the end of life, when you're moving into an end-of-life situation, I would say see them every day. I learned long ago from a family where I got the boots laid to me, because I was, went twice a week, or once every, and the family felt they were abandoned. Even though the nurses were there, I assume the nurses were providing guidance. It's important for the doctor to be there too, for people. So I would recommend going every day, especially when you get into subcutaneous and, last week of life care. And it's very important to also communicate with the staff so that people are all on the same page, not just the families, but the staff with people. Oops. Any questions at all? Does anyone have any questions or comments? Sorry I had to rush that one, but
Do you use the glycopyrrolate then for the secretions as well, or?
I have not been, mostly because it's not on the med card for most. Christine, do you want to comment glycopyrrolate versus
Yeah,
atropine?
I actually use glycopyrrolate often. And the thing I like about it is with the atropine, it's a tertiary amine, and so it's small enough to cross a blood-brain barrier. And it can, I wonder sometimes if it leads to more agitation, and it can affect the heart rate as well. The glycopyrrolate doesn't cross the blood-brain barrier, and so it has less likelihood. It's also a stronger anti-secretory, salivary anti-secretory, so if you think most of the secretions are coming from there, it's a good one, and it's just a Q8H injection. Where I use even more glycopyrrolate is farther upstream, when, say, someone's got a head and neck cancer and they're drooling, or in ALS. I will use it for drooling and ALS as well, because the atropine, I know the ALS docs use atropine, but I prefer glycopyrrolate for it. The other thing in this guy, if he's congested, it may be in part pulmonary edema, right, when he starts taking it, and you can actually off-label use subcutaneous Lasix. So you can give it a couple of times a day. It's a 20 milligrams per mil, so to get 40, you have to give it at a couple of different sites, but it can be quite effective, especially if they're getting that little bit of frothing, frothing at the mouth. You have to give it that way, but it's totally off.
I just want to ask a question too, because this is something you're going to get asked a lot of from families. When someone asks you, how long are they going to live? Okay, so someone is now not taking anything orally and they're bedbound, and you're about to commence subcutaneous treatment. What do you tell people? Does anyone have any?
You look back over the past month, see where they were, and project that a month ahead or a week ahead. So you say, this is how they were a week ago, this is where they are now, this is what you're going to expect in a week's time.
Yeah. Anyone else?
I try to avoid giving any specific date, and they're going to last for days or weeks or whatever. I'm very vague because you just get caught out.
Absolutely. One thing I find helpful is that when people stop drinking, it's rare for them to live more than 7 days. Okay? In this age group. So if you've got people now, they're drooling, and family's trying to hydrate them, but they're choking, so you say, it's okay to stop, we don't need to give them any more fluids because it's making them more uncomfortable. They're dying. Everyone's in agreement. I'm shortening the long conversation we have. They are dying. This is making them uncomfortable, syringing fluid in, it's drooling back out, and they're coughing and aspirating. So when people stop taking in oral fluids, it's unusual for people to live more than a week. So that gives people some guidance, right? When people are still eating or drinking, it's a crapshoot, right? And they can live for months, right, and longer. If they're still eating, and as they're drinking NHL or whatever they're giving them, But that's something that I think is practical for you to keep in your back pocket. And I'd say 95% of the time that's what happens. And I tell people they can go at any time, because a lot of people ask the family, is it important for you to be here when mom dies, or dad dies? Most people say yes, right? I say then you may want to stay, because it could happen any time, or have someone in the family or someone important be with them. And I don't want you to stay up 24/7 for 3 days. But if it's important that someone is there in the room, because in the facility, their staff are coming and going. And that's something that people, have said to me over the years, that there was no one with mom, in that last couple of days of life. And it was important for them that they not be alone. Any other comments? Or any questions? Thank you.
Thank you, Dad.